Okay, so I'm just kind of going to go over all the little skills that y'all did in mobility class the other day. That case study, y'all should have all the answers. We went over that in class, but y'all don't forget to read your books. And like what I said the other day, if you want to kind of see how well you retained all that mobility content, if you'll choose those 8 different body systems that are listed throughout your reading, like the metabolic system, respiratory, cardiovascular, skin, all that kind of stuff, and then try and think about your top 3 potential problems, your top 3 interventions to correct those problems, assessments that go along with them, and then also, how would you know if your assessments were effective? So that's your evaluation component, okay? And you have your Nurse Think notebook for mobility to help you to take notes, and you can put it right there, and that way you can build on that, for later content. So soft limb restraints, that was one thing that we did. And y'all have had restraints a couple of different times now. With restraints, there's chemical and physical. Our optimal goal is a restraint-free environment. So remember, you always want to exhaust all of those efforts prior to putting the client in restraints, and of course you have to have an order. What are some things that you need to keep in mind once you place restraints on somebody? You need to do what? Check on them frequently. And when you say check on them, what does that mean? Skin and circulation. So, should you still be able to palpate a radial pulse if you put this on somebody's wrist? Absolutely. You should not put it on there so tight that it occludes their pulse. Do they still have to be fed and turned and their elimination needs met? Yes, y'all. Just because we put somebody in restraints, we don't just restrain them and then leave them. And then what else should you be thinking about when somebody gets put in restraints? How do you get them off of restraints? Why are they in restraints? What is going on? Did they get a new medicine? Did they get some life-changing news? Always think, because it's kind of like discharge teaching. Once we do something, we want to immediately be able to, see what else we can do about it. All right, so that's restraints. Range of motion. Y'all remember, I told y'all please don't memorize that huge table in your book. You're not the therapist doing range of motion, you are the nurse doing range of motion. So what are the 2 types of range of motion? Active and passive. There's a couple of other types that are mentioned in your book, but active and passive are, the most common terminology. So what's the difference between the 2? The patient does active and you do passive, okay? So when we're doing range of motion, we're moving their extremities, correct? What would stop you from doing range of motion on somebody? If you meet resistance, if they complain of pain, could you delegate range of motion to somebody? Yes, but you better make sure what? That they know things like what you just said. You would not want to, go against resistance. You would want to stop if it was painful to them. What are the consequences of not performing range of motion exercise? Contractures. Can you fix a contracture once that happens? No. What are some different types of contractures? Who said that? Drop foot, foot drop. So remember, y'all, when somebody's laying in the bed, if they're 100% immobile, how are their feet? Like this. They can get stuck like that, okay? And as long as they're in the bed, they're fine, not really. But think about if they get better. Can you walk with your feet like this? No. So you have taken away any chance of them ever becoming ambulatory again. So what things would you do specifically, other than range of motion, to prevent foot drop? You could do high top shoes. You could put a pillow at the end. You could also do a footboard. But y'all be careful, because I've said this many times. Any good intervention, any good intention that we have can become a bad thing, okay? Just like we're preventing this, We're gonna put those high top tennis shoes on, and then we're gonna give them this, okay? Can they walk like that? No, they can't. So you have to be careful. It's that frequent monitoring, frequent assessment, okay? All right, that's all I can really think of on range of motion. And I'm just really hitting the high points, y'all, okay? Ambulating with the gait belt. So do we want to encourage ambulation on our patients? Yes. Why? To keep them mobile, but what does mobility do for us? It promotes circulation. What else does it do? Y'all think about those body systems that are discussed many times.
Elimination of
It helps with elimination. What else does it help us do? Breathe. You know, everybody in the sim lab, what y'all want to do for that patient? Sit them up, right? Because it promotes lung expansion. So if sitting somebody up promotes lung expansion, what do you think walking does for lung expansion? Okay, getting up and moving helps circulation, prevents impaired skin integrity, promotes elimination. I mean, does all of those good things. So what type of client do you think would need a gait belt? Somebody who's weak on one side, right? So when you put a gait belt on somebody and you're assisting them, how do you do that? Where are you gonna stand? Where are you gonna get? You're gonna get on their weak side, right? Okay, and kind of help them. And then what are you gonna do if that patient begins to get wobbly? The book says you kind of, when you're walking with them, you know, with a gait belt, you don't walk like in front of them and drag them with the gait belt, okay? You kind of are standing on their weak side, kind of behind them and helping to guide them. And then if they start to fall, you're gonna try to put your knee and let them slide down to the floor, okay? Do you think people are scared of falling when they're weak? So how could you convince them to get up and ambulate? What could you say?
Well, you'll be there with them.
You'll be there with them. So what if I ask you, are you gonna let me fall?
No. Well, I mean,
I just want y'all to think, be careful about offering that false assurance. No, I'm not gonna let you fall, and then they fall, and they're like, I don't want you to take care of me no more, because you lied. Okay? But what you can tell them is, I'm gonna use this belt for stability, and if you do get dizzy or weak, then we're just gonna slide to the floor and make sure you're okay, and then we can get a wheelchair and come get you. And then if they're still not convinced, then you can tell them things about all the good benefits of getting up and walking. You know, prevents pneumonia, prevents, you know, poor skin integrity. It's, you know, patients typically, if they don't want to walk, a lot of times they're probably complaining of constipation and they're wanting to have a bowel movement. And I'll tell them, you know, getting up and walking, that'll get you rocking and rolling, okay? Because all that moving, that helps to stimulate peristalsis, and that will help you, okay? So those are a few things about the gait belt. All right, what are these? What are they for? Preventing clots. Somebody said something about circulation, right? So go into a little bit more depth on how they prevent clots. What do they do? What's their function?
They push the blood back up the vessels to the heart.
That's right. That's taken, because y'all, you know, students can say those things, prevent clots, circulation, but what does that mean? Okay? And you said it, Dalton, say it again.
It squeezes the legs and it causes the blood to shoot back up to the heart.
That's right, because where do clots, the majority of clots, where do they form? In the lower legs, in the what? Starts with the V. In the, what's DVT stand for? Deep vein thrombosis, okay? Because the purpose of our veins, let's go back a little, A and P, is to return blood to the heart, right? Okay, so that's where your A and P comes back to y'all. So y'all please be careful and remember that. So we want to prevent DVTs. We're going to put TEDs on everybody. Do you just put them on there and leave them? No. How often do you remove them? At least once a shift is what they say. So, are these comfortable? Okay, somebody convinced me to wear them. What are you gonna say? Because y'all, your patients are gonna say, no, I don't wear them. I don't wanna wear them. Tell them what, Latrina? Okay, educate me. Educate me. I don't wanna wear them, I told you.
It's gonna keep you from getting a clot.
A clot?
I mean,
I didn't come out with no clot. I don't want a clot.
that's why you laying in the bed, the possibility of you.
There you go. And y'all, it's just, you know, she said it, you know, you're having to be in the bed, you're laying in the bed, you're at increased risk for getting a clot. These will help promote circulation. You know, you didn't come in with one, so we certainly don't want you getting one while you're here. You know, they can kill you, you know, not threatening you, I'm just saying, you know, it is a fact. Okay, so, you know, you want to provide good education because we want people to comply, and one of the main reasons why people don't do what they're told to do is because they don't understand or the way somebody asked them, you know? Here, I'm gonna put these tadpoles on you. You ain't gonna put these tadpoles on me until you tell me what they are. You know what I mean? So y'all make sure that you're talking and educating your patients, talking to them. All right, transferring from a bed to a stretcher. What if y'all had to pick the most important thing about transferring somebody from like bed, stretcher, wheelchair, any of that? What do you think is the number one thing you better make sure you do? Lock the wheels, okay? That's just a bad situation altogether because, you know, whew, that's scary because then you're just like, whoop, whoops. Okay, so please don't do that. Y'all make sure that you have, you know, adequate resources. You know, if you have a lift or something like that, you know, that's always going to be the easiest thing to do. Your book talks about, you know, how to use a draw sheet for proper lifting to prevent friction and shear. You know, friction would be something that the patient would get if you were moving them improperly, and then shear is typically caused by gravity. And y'all will see once you start, you know, pulling and turning on these patients this week that, you know, you'll have them sitting pretty up in the bed, but it won't take long for them to scooch. And when they do that, that's shear, that's the shearing force, okay, and they can tear their skin. So you just want to be safe during your transfers, okay? All right, a bed to a wheelchair. So if you're transferring somebody from a bed to a stretcher, then they're probably what? Immobile for whatever reason, whether they're, you know, like that, or maybe they've had a procedure where that's making them immobile. If you're transferring somebody from a bed to a wheelchair, then they've got to be able to do what? Stand somewhat, okay? So, you know, you want to make sure the wheelchair is locked, and if you're ambulating somebody, you're standing on their weak side for support. But if they've got to be able to stand to get in a wheelchair, then you want to put the wheelchair on what side? The strong side, because you want them to be able to help you. Because if we're putting somebody in a wheelchair, are we physically going to pick them up and put them in a wheelchair? No, you're not. They're going to have to get up and help you. But y'all think about patients who are not getting up and moving, okay? When we put them in a wheelchair, we're gonna sit them up and stand them up. What do you have to be careful of? Orthostatic hypotension, because you remember gravity, when you're in the bed, everything is kind of level, but when you sit up, you know, sit up and then stand up, where does the blood go immediately? Boop, goes down, and it takes just a few minutes for the patients to adjust, okay? So, you know, depending on how long they've been immobile, you may have to sit their head up, give them a minute. You may have to let them sit on the side of the bed, give them a minute, stand up, give them a minute. I mean, you just want to kind of be cautious, okay? And if they get weak and wobbly, do you want to get them to the wheelchair real quick, or hopefully the bed probably would be a little bit better. If you go to stand somebody up and they're just doing all this and buckling, then probably a wheelchair is not the best thing for you to use for that client, okay? we run into that all the time in the hospital. Patients will get, go for a chest x-ray. Typically chest x-rays, they're gonna be best if the patient can stand up, okay? They don't like to get them in the bed. But if you could barely get them in the wheelchair, okay, they're gonna have to get out of the wheelchair for x-ray. I mean, you just kinda have to gauge it, but you always wanna be safe. All right, let's talk about these different positions. Fowlers, there's different types. There's low, high, and all of that. Supine, they're laying on their what? On their back. And then you have Sims and sideline. What's the difference between Sims and sideline? Sims, you kind of have it like that. So y'all, a lot of y'all, when y'all were over here doing positions, you kind of positioned the mannequin, okay? And I didn't specify, so I guess it's really my fault. But I want you to think about something. When you are taking care of somebody who is completely immobile, they can do nothing, they can give you no help. We can put this mannequin on their side and they'll stay, right? I mean, you pretty much put them on their side and they'll stay. Can you do that to a real human being if they have no control of nothing? What are they gonna do when you put them on their side? They're gonna roll back over. They're gonna either roll this way or they're gonna roll this way into the bed rail. So what do? Use some support pillows, okay? Some places have really fancy stuff like wedges, and then some people have nothing and you have to get super creative with blankets and sheets. I mean, you just never know. So you wanna make sure that you're providing adequate support. So if you're having to change positions, first of all, how often do we need to change a client's position? Now, is that the end all, say all, 2 hours, end of story? What would make you reconsider that?
If they're uncomfortable, they need to move, if they feel pain.
Okay, so let's talk about that for a second. Cause patients, if they can talk to you, they're gonna ow, and wanna be put right back on their back right when you turn them. So we don't purposely want them to be uncomfortable, but they can't lay on their back all the time, okay? Because then that puts them at increased risk for what? Pressure ulcers, okay? So just kind of the wording of that, and I think that comes from a good place in your heart, but you can't let patients fool you, because what they'll say is they're gonna ask for you specifically on the call bell, because they know all they gotta tell you is I'm uncomfortable, I want to be moved back, okay? What if they were like you were turning them every 2 hours, but their bottom or their heels or their scapula were getting redder? What would you do? Turn them more frequently. I mean, every hour. I mean, and you ladies and gentlemen that work, that's hard to do when you got 5 and 6 patients, or if you work in a residential center and you got 25 or 30, or how many y'all got? I mean, y'all take care of a bunch, okay? But in testing, you got the time, you got the resources, you can do it if it's an option for you. Okay, so y'all just make sure that for y'all that work, that you're able to set yourself apart from your work environment, from your testing environment. So we're gonna put support pillows. Y'all said that. Where are we gonna put them? Be specific. I'm looking at you. Cause you said bony prominences, right? Where are they? Heels. Do these offer any heel protection? No. Do those SCD boots or those blue foot boots, do they offer any heel protection? The foot boots do a little bit, y'all, but I still want you to think about shear. It's still something up against the heel, okay? So that can't be the end all be all, okay? And you will see orders for things like float the heels, elevate the heels. So, any bony prominence. We go straight to the booty, because that's what we think about when we think about pressure ulcers, but y'all, they can occur anywhere. And think about your little chronically ill elder patient that is skin and bones, and you're diligent, you're turning them every 2. But think about what knocks together when you're turning them. Okay, so you have to be very, very cautious about that because it's easier, really, to come in, lay the head of the bed flat, take the pillows, take the covers, and just whip them and turn them, okay? That's the easiest thing to do, but that's not the best thing to do, okay? You still have to pay attention to everything else that's going on, okay? Oh, I'm out of my cards. Trying to think. All right, let's just, how am I doing on time? What time is it?
Yeah, you got plenty of time.
All right, I got plenty of time. All right, so let's go through some different systems. Respiratory, hazards of immobility for the respiratory system. What are they?
Pneumonia.
Pneumonia, what kind of pneumonia? Hypostatic pneumonia, what does that mean? Where's the fluid gonna go? To the base. So you have 2 minutes to do a quick focus lung assessment. Where are you gonna put your stethoscope? Probably the posterior bases, because what gets in the way on the front? Boobs, wires. You know, I'm just saying, y'all. I mean, all that, you just never know. Like, when we go to clinical, everybody's gonna be on a cardiac monitor. Think about it. 2 minutes to go in there and do a quick focus assessment. Where are you gonna go? What's gonna give you the best information? And y'all said it. Hypostatic pneumonia, fluid's gonna settle to the lower bases. Because what you'll do if you start anteriorly, just like your basic health assessment, you're gonna hear good flow. And then you may, by the time you get down here, you may hear nothing, okay? So you just, for accuracy, you wanna be careful. So what's gonna help prevent hypostatic pneumonia?
Cough, turning, deep breathing.
Huh?
Coughing and turning and deep breathing.
Okay, explain that to me, cause you know.
Uh-uh. You have to, deep, you have to, I tell them to take a deep breath and like, excuse me, y'all.
Put your mask back on, Aegis, before you cough the Rona out into the group, okay?
Deep breath, and the third one you, deep breath and you cough out.
That's right, and that's what your book says. Take some deep breaths, and the third one you cough out. And what if they say, well, I don't want to cough any stuff up? We want you to cough stuff up, okay? We want it to come out rather than stay in, because if it stays in, it's a warm, wet, moist environment, and that's how pneumonia grows. What else you gonna do besides turn, cough, deep breathe?
Keep the bed elevated.
Keep the bed up. What else? Huh? Incentive spirometer, that's correct, okay? Because incentive spirometer treats atelectasis, which is lung collapse. And if you're in the bed all the time, you're not deep breathing, so you get lung collapse, which leads to hypostatic pneumonia. What else you gonna do?
Fluids,
Why?
it thins the secretion
So that they can cough them up. That's right. So, and that's not all of them. Those are just some of the ones that I was thinking about, you know, but your book lists them. What about musculoskeletal? What problems can they run into with the musculoskeletal system? The immobile client.
The contractors.
Contractures, and we know how we're gonna prevent them, right? Now, do you have to say, do I have to go to Jessica and say, all right, I'm going to do range of motion on all my patients now, I'll be back? Should you be incorporating range of motion with everything that you do, right? Health assessment, bathing, turning, positioning, all of that. You have a great opportunity. What if your patient is one of those good ones that's like, what can I do to prevent any problems? How could you tell your awake client to prevent foot drop? What could you tell them to do? Rotate their foot. And it's like, rotate my foot. How about make the letters of the alphabet with your foot? You know, that will help. What about cardiovascular changes? Do you think your heart works harder or lighter when you're laying in the bed? Harder. Why?
Because the blood can't get out to those different areas.
That's right. That's right. So, you know, your heart is actually working harder when you're in the bed. Okay, so you may see things, you know, with vital sign changes and things like that that indicate that. DVTs fall under the cardiovascular system, and we know the things that we're going to do to prevent them. We're going to put on TEDs or SCDs, and when I say we're going to put them on, I mean we would have an order, you know, and all of that. what would prevent you from putting TED hose on or SCDs, or what would make you question an order from the provider? Maybe some skin breakdown. What else?
If they already have a DVT.
Because what's going to happen if they already have a DVT and you put these compression devices on them? You're going to change it from a thrombus to an emboli, and that's dangerous. Okay, so you still want to do good assessments, and then under the cardiovascular system, we have to worry about safety and orthostatic hypotension, and y'all know the things to do. That. What about nutrition? Does immobility affect your metabolism? Yes. It does. So, you want to do things to, help them. Protein. We lose a lot of protein and muscle wasting when we're immobile. So, a lot of patients will be on a high protein diet. So, could you recommend a diet high in protein for your immobile patient? So, give me one. What if baked chicken is not a choice? But y'all see where I'm getting, foods that are high in protein. I'm trying to think. Elimination. What types of elimination problems can occur for an immobile client? And? Yeah, urinary retention, okay? Once again, gravity. Gravity's our friend when it comes to our bladder, most of the time, okay? So if we're up moving, our bladder and all that, I'm not gonna get into AMP because I'll get my wording all mixed up, but it's supposed to go down and come out. I'm pretty simple, okay? But when you're in the bed, you can get some retention and some reflux. And, when you have those problems, that can lead to another problem, such as what? Urinary tract infections, bladder infections, and stuff like that, okay? So what are you going to do besides early ambulation to help with the urinary system? Increase fluids. Can you do that on everybody? No, y'all are going to have to look at other underlying factors. If they have renal problems, if they have cardiovascular problems. So you have to look at the whole picture. I'm trying to find Jenga. Anybody got Jenga at home? Thing brain? I'm trying to, because I'm visual, so I really like those blocks. But you have to think about all the pieces and parts of your patient. Getting up and walking them. Do we just want to cath them? We want to stick a catheter in them? No, because that's going to increase their risk for what? An infection, a UTI. So we want to promote that. And y'all will get more in depth on elimination in the weeks to come. Y'all get a whole 4-hour class on that. Constipation. What are we going to do for somebody who's constipated? If they have some impaired mobility. Increase fluids. Okay, because that's good. When you start, so that's why y'all ask when y'all do y'all's basic health assessment, how's your urine, are you urinating, are you having bowel movements? What does it look like? Describe it. What would a constipated stool look like? Rabbit pellets, rocks, okay? And really, that's what it looks like. So when your patients are describing those things to you, don't just take the description and move on. It means something, okay? Just like the concentrated urine or the smelly urine, that means something. So take what you know and then put it to good use, okay? So you're going to increase fluids. What else could you increase? Fiber. So what are some good sources of fiber?
Green leafy vegetables.
Green leafy vegetables, fruit juices, stuff like that. Do you want to just run in there and give them an enema? No. Y'all remember we want to do least invasive things first and then kind of move on forward. I'm not saying they might not, get to the enema, but y'all think about this. What if the patient has been on the ventilator, a breathing tube for a week, okay? And they have not had any feedings or anything started. They come off the ventilator, they're awake, they're doing good, but they haven't had a bowel movement in several days, okay? Say Jessica wants to run in there and give them an enema. Is she going to get any results?
No.
Why not?
The watery stool.
They haven't eaten, okay? There's nothing to come out. Okay, so y'all have to think about that, but as nurses, we're quick to wanna act before we really think, those, that get our thought process into gear, okay? I'm trying to think about the other systems. We talked about skin a bunch. Let's see. Make sure I'm not missing anything. Can y'all think about any other systems while I'm looking? Nothing. I know I'm missing some stuff. Huh? The what? Endocrine. Oh, I want to talk about that one. That's hard. Let's see. Talked about all of them. Oh, I know something we didn't talk about. Where's calcium supposed to be? In your bones, in your teeth. Guess what happens to patients who are have prolonged mobility issues? It does cause osteoporosis, but by what way? The calcium leaves the bones and goes into the circulatory system. And if the purpose of calcium is to make bones strong, then bones become less strong and they're at increased risk for pathological fractures. So if you have somebody who has osteoporosis and they fall, they're going to be at very, very high risk for a fracture. And we pick on the black male all the time for the poster child for hypertension, non-compliant hypertension. But guess who's the poster child for osteoporosis? White ladies, fair hair, that smoke. So if you're in that demographic, you probably got some porous bones coming to you in your future, okay? So you want to be mindful of that. Also, women who have gone through the change of life, they're at increased risk for osteoporosis, menopause. Y'all don't know what that is. Trying to think. But y'all, basically, what I want y'all to get out of it is mobility issues, immobility, it affects every body system. And then don't forget about the psychosocial aspect of immobility, okay? Does that cause some problems? Somebody who is immobile? I think about a paraplegic or a quadriplegic. A lot of times that happens to people, young in their life. And so you take somebody who's supposed to be, going to school and going to college and, making a new life for himself or herself, and they're immobile for whatever reason and they can't. There's gonna be some psychosocial aspects. Your elder patients in the nursing home, if they're immobile, they're gonna have some psychosocial problems with that. But anyway, all right, that's all I got for immobility. Y'all got anything else? Please feel free. Now's the time. Okay, so y'all can email me, if you want to later on if you don't want to ask in class. Miss Cootie, because she's teaching, she asked me to demonstrate and talk a little bit about NG and PEG, because she put up some videos but she didn't have time to demonstrate. Is that right? Okay, so I'm gonna do my best. It's been a while. I did not pre-read, but I think I can do it. All right, so biggest problem, biggest consequence with enteral feedings, and y'all, it's not internal, it's enteral, okay? What's the biggest consequence, the thing that you are most concerned about? Aspiration, okay? So what does it mean to aspirate something? Goes into the lungs, because what does aspiration lead to? Pneumonia, okay? So what are gonna be some things that you are going to do, whether it's a nasogastric feeding, or a PEG feeding, or if you're just helping them eat their eggs. Elevate the head of the bed. What else do you need to assess for? If you're feeding them. Their ability to swallow. Okay, y'all, that's important, because you don't want to give somebody something and then them choke on it. Do you think feeding is a task that gets delegated? It is, and it's an appropriate task to delegate so long as you know the patient can swallow. And y'all, a lot of people who have dysphagia, difficulty swallowing, they can do it, but you just have to be careful. You want to make sure that they're on what kind of diet? Either a pureed or a soft diet. I mean, you don't want them in there trying to gnaw on a pork chop. or a chicken leg or something, you know, but y'all, you think that doesn't happen, but people get wrong diet trays brought to them all the time, and they think, well, maybe my provider changed the diet and I can eat this now, and then they get choked and strangled and die, and that's very sad. All right. So you ladies and gentlemen that work, y'all are gonna find this hard to believe if you don't already know. Your book talks about different things for putting down an NG tube and the way to check for placement, okay? If we're putting down a nasogastric tube, where do we want it to go? We want it to go in the stomach, right? But it can also go in the lungs if you're not careful. Okay, so this is a nasogastric tube. Yeah, there's all kinds of different kinds, but this actually looks like a KFed tube. It's little, that's okay. All right, so if we're gonna put it down, we gotta know how far to put it down, right? So how do you determine that? Yes, y'all, landmarks are key. Please don't just say, you know, to the top of the stomach. I mean, you got to know those things. So tip of the nose to the earlobe to the what? Xiphoid process, okay? When y'all get into medication administration and learn about IMs and all that, it's not going to be enough to say I'm going to give it in the butt, hip, or the arm, okay? You're going to need to know what those things are called. So when we're gathering our supplies for nasogastric tube placement, what all do we need besides the tube itself? You need some water, a syringe, what else? A towel. What might the patient do when you go to put down this nasogastric tube besides bite you tooth and nail? Gag, and then gagging leads to So, you know, you would have a towel, you would have a basin there in case they vomit. It's always nice to have help too, you know, but sometimes we have that and sometimes we don't. Y'all don't be afraid in your patient's room to turn the bright lights on. You need to be able to see what you're doing. Now, is this a sterile procedure? No, it's not, okay? So, but I mean, you don't want this, I mean, you don't have to have on sterile gloves and stuff is what I'm meaning. Now, you don't, the tip of this is going, you know, in their nose or, yeah, in their nose and down in their stomach. So, I mean, you don't want it just flopping everywhere, but you don't have to put on sterile gloves. All right, so I'm gonna need some water. I'm gonna need a syringe. Gonna need some what? What's this? Lubricant. Let me just show y'all the difference here. And this one doesn't have it, but this looks like a KFed. These have a wire in them, y'all. And because these are kind of like, when you go to put it down, you know, they're not real stiff, so they're hard to get down. So they come with a wire in them, just so that can help you to put them down. But the wire has to be removed prior to feeding, okay? So that's kind of the trick. And you know, KFed is what I usually refer to them as. They're great for feeding, but not really for anything else, because medicines get stuck in these like crazy, okay? This is a nasogastric tube. This one is a little bit, you know, it's supposed to be stiffer. This one's not, but these are typically a little bit bigger than those. But it really, you know, whatever you got to order for is fine. Okay. So, do I need this? Yes. What are these for? These are pH strips. Why do we need these? Okay, because what is stomach content supposed to be? Acidic. Okay. Now, do you see these in the hospital? Nope. But your book talks about it, so we better use one. All right, so I've got a syringe. So this is a 60 ml syringe. This is what you want to use. All right, so I'm going to measure. Got the bed. I would have on gloves, of course, wash my hands, identify the patient. Y'all, that goes without saying. So tip of the nose to the earlobe. to the xiphoid process, okay? So am I gonna remember right here? Sometimes they have markings on them and you might can remember, but I have to put some tape on it, okay? So put some tape on it. Now, stick it in your lube. You wanna lube it real good. How do you know, cause you got 2 nares, how do you know which nair to go in? Closest to you is good, but what else might you wanna think about?
Make sure it's not included.
Make sure it's not occluded, make sure that, they have not had any nasal surgery, you know, if you can find that out, cause it'll just make it kinda difficult for you, okay? So, how do we want them, when we go to put it in, do we want their head this way or this way? Back, okay? Now, when we, have this lubricated tip, where do we point to? Like, when we insert it? Okay, that's right. So you wanna go down, and something that I don't know how far it's really gonna go in these mannequins. Not very far. Well. When you're putting them in for real, y'all, if you'll do like a little twist, okay? And then we wanna make sure that it's not gathering in the back of the throat. So you may need your flashlight to look, especially if your patient can't say, you know, Al, what do you think they're gonna be doing as it passes the nasal cavity? And you just say, all right. And then if they're awake and alert, you can have them lean forward, swallow, 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 stop. Okay, I'm at my tape. What's gonna happen if you let go? It's gonna come out. But am I ready to like put, not permanent tape, but am I ready to like tape it down, like tape it good right now? No, because what do I need to do?
X-ray?
Yes, why the x-ray?
Check replacement.
Check replacement. Now, we said we were gonna use this to check replacement, right? But if you had the choice between pH strip and x-ray, what's your best choice? X-ray. So x-ray, you know, they usually come up into a portable, maybe they might take them down. Once you get your placement verified, then you can begin what? Your feedings, okay? Should you begin feedings if the patient has not had x-ray confirmation? No. Now I'm gonna let it go right there for now. No, why? Because y'all, and some people will say, well, the pH strip, it was an acidic reading. What could they have done? They could have reflux, and so they could have some stomach contents in their esophagus. So your x-ray confirmation is going to be the best. What if when you're putting down the tube you meet resistance? Do you just like, you know, I mean, I know I'm kind of aggressive, but you know, y'all don't be me, okay? So when you're putting it down and you meet resistance and they start bleeding, what do? Do you take it all the way out? Tell me why not. But y'all think, what do you think is the worst part? It's that initial passage, putting it in the nose. So I'm not saying you might not have to take it out, but if you can pull it back just a little bit, give them a few minutes to kind of adjust and then start again. And then if you still meet resistance, you know, you may want to pull it out and go to the other nostril. Is this uncomfortable for your patient?
Yes.
Yes, y'all. And sometimes, like when I was telling the mannequin, swallow, 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 if you're able, sometimes you can give them some ice chips to assist them to swallow, because swallowing just helps facilitate, you know, the tube going down, okay? So, now we're going to do that. We would, you know, take this.
The book,
Go ahead.
the book say you only do it when they at what? X-ray, not infrared.
Ma'am?
The book say you only inhale it, I mean, you only insert the tube into a further degree when they inhaling.
Okay.
And when they, yeah. Okay.
I mean, I just, you know, I'm sorry. Yeah, whatever the book says, yes. Okay, so y'all, this right here, this just drives me insane, okay? Let me just tell you. Don't do this stuff. This one won't go. This is not a cap, okay? Don't do that, okay? And I know you see it. You see people do it all the time. That's not what that's for. This is supposed to hang out freely. They make caps that can go in these things, okay? So if I'm putting this down for feeding, you wanna be careful about leaving this wide open because sometimes they may cough and stuff will come out and seep out. If you have feedings going, then your feedings will leak out. If you're putting a nasogastric tube down because they need their stomach decompressed because they have like an ileus and they're not digesting substances, then stuff is just gonna start pouring out to ooze, okay? This can be hooked up to suction and it can suck out their stomach contents, and they'll talk about that with elimination, okay? So if we wanna get some residual to check a pH, you gotta take the tip of the catheter, the syringe off. You put this in, and you pull back just a little bit. It doesn't take much, to check the pH, okay? And then what do we do with what we pulled out? Why? You did. You said you pulled it out and put it back. Why do we put it back?
Maintains the fluid and electrolyte balance.
Maintains the fluid and electrolyte imbalance, okay? Because what are you pulling out? All kinds of good stuff that they need, okay? So you want to make sure that, you pull it out, and then y'all will get good at maneuvering, clamp, pull it out, do that, and then you can put it back if you want to, or you can clamp it. All right, I know some of y'all have probably, are still injecting air. I'm not even gonna go into that because the book doesn't say it. All right, so if you're putting down the feeding, you may have specific orders from the nutritionist or dietitian that tells you to assess gastric residual. If you have greater than 200, hold the feeding, continue the feeding, decrease the rate. I would not get so hung up on that kind of stuff studying because you will have specific orders that will guide you, okay? When we put somebody on continuous feedings, like on a pump, that's increased gradually in increments. Why do you think we do that? So we can make sure they could tolerate it. How would you know if they were not tolerating it? Nausea, stomach cramps. Now, a lot of times they won't stop feedings because of diarrhea, because of the high sugar content that is in the feedings. A lot of people who are getting tube fed or peg fed, they have diarrhea. That's just part of it, okay? But definitely if they were nauseated or cramping. What about the appearance? Could you tell just by looking at them? What's the first part of an abdominal assessment? You're supposed to do what? Inspect. If their belly was big and distended and they had hypoactive bowel sounds, would that be something you would take into consideration if they were being tube fed? Yes, it would, okay? So, if you're gonna check for residual after they've been on feedings for a while, it'll come out pretty easy. You don't have to like bear down on it to pull it out. It'll come out, and then you would, clamp, have a cup. And then I've filled up 10 cups before. It just kind of depends on what's going on with your patient. Now, if you got to feed through a nasogastric tube, you take your plunger out, okay? You have to make sure it's clamped. What do we do before feedings?
Water.
Okay, well, you have to make sure your placement's good, okay? So you're looking for that x-ray confirmation. You're going to flush with water because you want to make sure that your tube is patent. Okay, but if you had a choice between patency of the tube or checking for placement, what's your priority? Okay, because your tube may not be working, okay, but if they aspirate, they could die. Okay, so that's how you determine what's the bigger priority. So we're going to have our water. What controls how fast or slow this fluid goes? Gravity, okay? So we've got, how much flush do we do? 30. It's about 30. Orders may vary some, okay? Now, if you're giving pills, y'all, the book still says you crush one pill, flush before, flush after. That's totally ridiculous, but that's what Potter and Perry says. That is what you will be tested on, okay? That is not, I know. But that's what all the research supports. They didn't ask my opinion because I sure would have given it to them. But anyway, you want to flush beforehand. So if I pour the water in here, 30, then I'm going to let go, and I'm going to let it go. What do you want to prevent from going in this tube? Air. Because what's the air going to do in the stomach? cramp it and blow it up. Okay, so you need to have all your ducts in a row. And you get fast. Like you can whip out this, you can have your, I don't have my can of feeding, we'll pretend this is a can of feeding, and then you can control it, okay? What if they start cramping? What do? What's gonna stop it? Do you just take it all out and say, well, I'll come back later, honey? No. Okay, lower it down, rise it up. And then once you get your feeding done, then you flush it again, okay? And then you cap it off or do whatever you gotta do. And y'all, the PEG tube is the same way, okay? Sometimes people have continuous feedings where it's on a pump and it's going all the time, and then a PEG tube and an NG, they can have bolus feedings where it's like every 4 hours they get X amount of whatever their meal is. You know, it usually comes in a 240 milliliter can. Okay, so the video is probably much better than what I showed you, but you know, it is what it is. We're trying. This is what the can of food typically is. So y'all, this can says 237 milliliters. We're gonna learn INO tomorrow. Y'all think INO gets complicated with all this going on? Because what do you have to consider? The flushes before and after, and the feedings. When you give medicines, do you flush before and after you give medicine? Yes. So y'all, you know, y'all can pretty much expect some INO questions, not on test tomorrow, but test in the future, okay? So y'all make sure that you're paying attention to flushes and all that kind of stuff, okay? I think that's pretty much it. Do y'all have any questions? I tried to hit as many high points as I could think of. Safety, y'all. Safety is key. We want to prevent hazards from occurring, so think about ways that you can do that. Think about ways that you can assess interventions that you can do, and then how do you know if your interventions were effective? I'm really pushing the thin thinking. You know, y'all, that's great stuff. T stands for top 3 priorities. So take the top 3 with everything that you've learned, okay? H, you know, is what the question is asking you. Is that a help quick? Meaning, do you have enough that you need to act right now because you got to help? The I, are they at risk for anything? And then identify that risk. And then the N, for nursing process, the 2 biggies that you'll see for nursing process on testing is, do you need a further assessment to make a decision, or do you have enough assessment information that you can intervene? Okay, that's how you need to look at testing. Any questions?